Welcome to The Whole Pineapple. I'm Ruby Boris.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. We'll talk with experts on a wide range of topics, including nutrition, stress relief, sleep, mental health, etc.
And we'll dig into the issues that can cause fertility challenges, like PCOS, or early menopause, or cancer treatment.
So if you're curious about your fertility, whether you're ready to start a family,
or you're preserving your options for the future, let's dig in. Welcome back to The Whole Pineapple, everyone. We have an episode today that it's been on our list for pretty much since the beginning of the podcast. It's even in our intro. So we are covering fertility preservation for those that are undergoing some sort of medical issue that might interfere with their fertility. And we have a wonderful guest today. We're speaking with one of our very own from Seattle Reproductive Medicine, Dr. Lynn Davis, who attended University of Virginia, where she double majored in biology and psychology. She then went on to attend medical school at the University of Colorado. She completed her OBGYN residency at Harvard and received her master's in health research and policy from Stanford University. She concluded her training with her REI Fellowship at Stanford University, where she also completed a postdoctoral fellowship at the Stanford Agency for Healthcare Research and Quality, and served as a clinical instructor in the Department of OBGYN. In addition to receiving many awards and recognition, Dr. Davis developed and leads our fertility preservation program, where she works with patients who are about to go through fertility-altering medical treatment, such as chemo and radiation for cancer treatment and other conditions that may lead to infertility or delayed conception. In addition to oncofertility, which is that fertility care of patients with cancer, the fertility preservation program also assists transgender individuals to preserve fertility before gender-affirming hormone or surgical care. And in addition to all of this, Dr. Davis is a wonderful, knowledgeable colleague and overall lovely human being, and we're really happy to have her today.
Yay. And she was a little nervous to come on, so we are very extra appreciative because we kind of voluntold you had to come be our guest.
We've totally voluntold her to come on.
I am here willingly. Thank you so much for that kind.
But how did you get interested, first of all, in focusing in REI and then also going more down this fertility preservation path? Because you did a lot of things. Like, I always think it's so impressive how you have that extra interest in research and health policy and all that too. So yeah,
the question is, how are you so awesome?
Very sweet. I guess I've always been interested in reproductive endocrinology, even before I knew that it was a field. My most interesting class in all of high school was biology. My most interesting class in all of college was endocrinology. And then after I got out, I did research to start by happenstance at University of Washington under Dr. Robert Steiner in his lab. And that's when I figured out that this was even a specialty. And I knew that if I went on to medical school and then matched an OBGYN, that then possibly I could do reproductive endocrinology and infertility as a subspecialty. And that's how it all panned out.
Was there a part of you that thought you wanted to do all research? Like, I just can't picture you being completely clinical based because you're so good with human beings and having these big discussions.
Way back in college, I actually thought I would just be a biologist. I didn't know what a biologist was. I figured I would just keep staying in school and studying and then go to the lab and be like a school lab rat and just do scientific experiments in the lab. And then right before I graduated from college, I had a National Science Foundation summer fellowship, and I did research in this guy's lab who was an MD, PhD, and he was a pediatric endocrinologist, and he invited me to shadow him and go see patients with him one day a week. And I just completely fell in love with clinical medicine. And I had a upside down turnaround and realized right then that I had to do clinical care. So that really set a trajectory for the rest of my life.
And what about being interested in fertility preservation?
The idea that somebody could come down with a medical diagnosis that not only put them through the angst and anxiety of something that's potentially life-threatening, but you add then the threat of infertility to that at the same time. And I just think it's more than any one person can bear. And I feel like you can't take away more than one thing at a time. And fertility preservation is one of the most important characteristics around the survivorship, quality of life, what's important to people once they do survive their cancers or their, terrible diagnosis, what's in store for them for the future and what gives them hope. I feel like I just naturally gravitated toward this ever since the beginning of the field, which kind of coincided with my training. It's a nascent field. It's only been around for a decade and a half, 2 decades. And that's around the time that I was coming into my own anyway. So it all just kind of fell into line.
I think that's one of the things that most people are probably a little bit surprised by. I feel like you hear so much in the media right now about, people electively freezing their eggs, and all this seems so common, and you don't realize how relatively new this focus is. You and I have both done a lot of outreach in the community for fertility preservation for those facing cancer diagnoses. And every time I still show that little timeline that, it's only in 2004 that you have this panel and guidance issued saying that, hey, maybe we should address concerns of infertility. I mean, that's less than 20 years that this even became a thing that oncologists started thinking they should talk about. And there's still a long way to go. So this is still something that we want to talk about more. And that's kind of why we wanted to do this episode of the podcast. Do you know what information is out there about, how important fertility is as a concern for survivors? Or
it has really made great strides in the past many years. I just can't even tell you the difference between now and 15 years ago. Our relationships with the oncologists in the area, how interested and eager and involved they are to get fertility preservation discussions going early. It was so hard to move the needle at the very beginning. And now I feel like so many more of these relationships with us and the oncologists are going so well, so smoothly. They know to call on us to talk to their patients. They're busy. They're trying to save lives. They honestly don't have the time to do an in-depth discussion around fertility in addition to everything they're doing. But the difference is that now it's really a top priority, and all of the cancer centers that are, centers of excellence do incorporate fertility preservation reliably now, which is remarkable. Big difference.
Within the time I've been here, I've noticed a trend too, where when I first started, it was a lot of patients that are self-referring after they got their diagnoses. And now daily we get emails from oncologists that are saying, hey, I have this patient. Will you talk to them?
Absolutely.
And I think a lot of that is also the evolution in the field. I mean, like you talk about that overwhelming diagnosis. I can't imagine being a single woman and being told, hey, and if you want to do anything, pick a sperm donor and make some embryos. And you're like, that just seems like way too much to consider. So I think a lot of it is the availability of the option to just freeze eggs, and the way that we do egg freezing being a faster, easier process now than it was even in the beginning. And we'll go over that a little bit, like how is a cycle for a fertility preservation when we have this limited window of time a little bit different than someone that's doing it as more of a social, I'm delaying childbearing, I don't have any like month-to-month time rush. But I mean, that's a huge change. It used to be we have options for sperm, and we'll talk about that. But for those with eggs, I mean, it used to be we weren't good at freezing eggs. And so you could do kind of the old school IVF and freeze some embryos, but that wasn't an easy thing to do if you were single.
Right. Egg freezing really has, I think, changed the whole field. Thank goodness.
Yeah, because the level of decision making that you have to do after a cancer diagnosis or other major medical condition is so challenging. And then add on top of that, now you have to make all these decisions about your fertility. So it's nice that we have some other options now.
Let's talk a little bit about that timeline. So, we mentioned that 2004 being this panel, and that's also, I think, when ASRM formed their like special interest group, right? In terms of having fertility preservation as a topic. So again, that's another example how this wasn't even considered a big enough area of the field to have its own little group until 2004. What are some of the other key events in terms of moving ahead fertility preservation?
I think some of the main ones have been when the American Society for Reproductive Medicine deemed egg freezing no longer experimental, but rather standard of care, and that was 2012. And then they went on to deem ovarian tissue cryopreservation no longer experimental in 2019. These were some of the main things that happened in our field that really revolutionized fertility preservation.
And tell people about why that's so important. What does it change in terms of like a payment and insurance and everything else when something is no longer considered quote unquote experimental?
Once intervention is no longer considered experimental, the hope is that there will be more justification for a plea to insurance companies to cover this medically indicated care. I think that's another problem that we have in the United States is lack of reliable insurance coverage for fertility preservation. even when there's a medical indication for it, and even when it's iatrogenic, even when the medical system is going to cause the infertility, there's still not been any reliable coverage across all of the states. Moving forward with these designations by ASRM to be no longer experimental, the hope is that and coverage will improve. It is improving slowly over time, maybe not as quickly as what we would like, but the hope is that it'll continue moving in the right direction at least. And mostly it's going state by state and probably won't be a federal determination.
Well, yeah, if anyone's ever had to deal with their insurance company, you know that time is also not usually on your side for that either. So that's the challenge. Even if someone thinks their insurance might cover, if they have to do endless appeals and calls and authorizations, again, we're usually working with this very limited window of time. And so often people that might eventually be able to fight and get something covered usually don't have the time to do that because we are working with these limited windows. So I think you're right, having some sort of policy that would just make it easier in terms of any sort of mandate would be huge in terms of reducing the stress for people who are having to decide if they can afford as well as can take the time to preserve fertility before treatment.
Yeah, and I don't know if this is a podcast that'll be listened to outside of Washington State where we are here, but things are changing quite rapidly in Washington State. In Olympia, there's this grassroots effort towards increasing access to care, and it'll be picking up in Olympia this legislative session in the Senate. And if it can make it through the Senate and the Appropriations or House and Ways Means Committee and get to the governor's desk for a signature, it could possibly be something that's legislated as soon as a January 1, 2025 timeline. That would be the earliest possible. So we can all hope for that.
Yeah, we've been hoping, I think that for the lifetime of this podcast, we've been talking about it.
I know, we did a big advocacy day last year, but this is government, and that's the challenge. And like you said, even best case scenario, if it passed, that doesn't help people that are going to face this diagnosis in the next year either. So, a lot of people do end up having to kind of self-fund. And luckily there are a lot of organizations out there that can help a little bit with the cost. And I know our clinic, and I think a lot of others, give a discount on the price when people have a diagnosis. So definitely, if you're facing a cancer diagnosis, it's always worth having a conversation because that way you at least are making an informed decision. And that's one of the challenges about this is part of that counseling is there's so much uncertainty. Two people that have the exact same diagnosis may end up having really different fertility potentials because treatment doesn't always go exactly as planned either. So it's not like anyone can give you the crystal ball and say, oh, I'm sure you'll be fine, or, oh, yes, you definitely will have no chance. It's tough. And that makes it really hard for people to decide how important the costs and the physical strains and the delay of preserving can be and whether it's really worth it for them.
And the last thing that you want to add is the additional financial stress. So the programs that you had mentioned with a compassionate care discount, I think those are really important and you can draw on reliably. And then medications, which can be quite expensive that are needed for things like egg freezing, can be at no cost to patients with a diagnosis of cancer. So that helps quite a bit bring down the total cost, at least.
Yeah, there are definitely programs. So no matter where you're at, it's worth having a conversation with a reproductive endocrinologist because we're aware of the programs in your state or in your country too, if there's different programs and things. So it's always worth looking into for sure.
Well, let's talk a little bit about the logistics. I feel like we've been talking so much about egg freezing because that tends to be the one that is the hardest for people to decide whether or not to move forward because it does involve more of a time and more of an expense. So let's talk about the easier one. Not to say it's easy, but people that, have sperm and are facing a diagnosis that might impair sperm production in the future. I mean, this is just one of those, it seems like it should be medically negligent for me for anybody to not talk about banking sperm because it's such a relatively small cost. Most banks will give a very discounted storage fee for frozen sperm if it's done because of impairment for a cancer diagnosis. And usually we're talking about not a delay in treatment. People can often call and get in like that day or next day to come freeze sperm. Mm-hmm. So for people that are able to produce a sample, masturbate, give us that sperm sample, I feel like we still aren't doing as much sperm freezing as we probably should do.
Yeah, but so important. And as you say, there should be the fewest number of obstacles for this fertility preservation intervention because it's one collection or more that could make all the difference. And speaking of access to care and what insurance companies may cover, we've historically been having this problem of an insurance company considering one banking episode, one collection to be adequate. The truth is sometimes it is enough. What if there's very high sperm parameters and you can take one collection and divide it into multiple aliquots for even more than one IUI or more than one IVF cycle or both? But many times sperm parameters are normal or low in people with a cancer diagnosis, and they might need multiple collections. People can collect, every day back to back or every other day within a short period of time before the start of cancer treatment. And we at ASRM this year just presented findings of expert opinion-based questionnaire style study to say what is considered adequate sperm banking. And the consensus is 3 collections should probably all be covered by insurance. Sometimes people are going to need even more than that. Sometimes people might really cover their bases with only one collection, depending on sperm quality. But the hope is that we could take that to the next level and show that more coverage is actually appropriate.
Especially if you're thinking about healthcare costs in general. If you pay for someone to freeze one vial, you're basically committing them to IVF in the future,
That's right.
And so then you're spending a lot more money down the road than if you were able to bank enough samples to, as you mentioned, be able to potentially do that lower cost treatment of just inseminations, which is also what a lot of people would prefer. People would like to often have what is the least invasive path to parenting in the future, and having more sperm banked is certainly giving you more options. But I also get the flip side of that. Sometimes people, they only have time for one sample and then the quality is really poor. And we've had people ask, well, should I even preserve it if it's so low? And that's another thing we're like, oh, absolutely. Because that's still, with the option to do IVF, we can have good success rates with a very minimal amount of sperm. And we just don't know what things are going to be like in the future. Often the counts may be low or impaired just from the illness that this person has been undertaking, especially the leading cancer diagnosis in men in those reproductive years of younger men is testicular cancer. And so often we are finding people who have maybe never tried to get pregnant, never done a semen analysis. This is their first sample and the quality is low, but it's still preserving their genetic material in a way that, we might have options with in the future. And if they end up having a good rebound after treatment and their counts look great, well, then you can always discard that sample that you froze that was poor quality. But if you end up not having any sperm at all afterwards, that sort of less optimal in terms of the counts and numbers is still better than having no genetic material of yours preserved.
There's 2 more things that I would love to add to that. One is just that sometimes people get a new diagnosis and they think that they're maybe not going to have the type of treatment that would make them azoospermic, wipe out all sperm parameters. And they think, well, is it really that important to do? Maybe not initially, but they go through a chemotherapy and aren't contemplating fully the possibility of a relapse. And if a relapse occurs, they might end up needing to have something more intensive in terms of their cancer treatment, and then only be able to look at sperm banking after the chemotherapy has been initiated. So it's still better to do it up front if you get this opportunity the first time around. The second thing I wanted to be sure to mention is that if you happen to not live in an urban setting and you don't have a fertility center next door, don't fret. You can still do your sperm banking literally through the mail. There are options for how to do it, how to access it, even if you're in a rural setting and you don't necessarily have to do a long drive in. You might be here already for your cancer treatment at the cancer center, but if you are rural, don't let that be a barrier.
I think it's also good for people to realize that, there's just uncertainty. A lot of people sometimes, if they already have a child, might think, well, we probably didn't want to have any more. There's that sense of like, you may not think you want to have children in the future, either any at all or additional, but then sometimes life circumstances change, and it's always a little bit better to have something and not need it than to have, this desire change in the future. So I think a lot of people, if they knew they were already desiring to have either children or additional children, they're far more likely to think about this, and if it's something that they don't foresee themselves using in the future. But we see patients all the time that have come in because circumstances have changed, and suddenly now they are wishing to have more options for conception than they thought they wanted 5 or 10 years ago.
It's a really good point.
Usually, the idea is hopefully we can get sperm just from a sample from an ejaculation, but we also do have that option for surgical retrieval. So sometimes, as I mentioned, plans changing. If you had someone that, for example, thought the family was complete, they had a vasectomy, but now they're facing potentially complete impairment. There are some people that might want to take some sperm from the testicles surgically and get those frozen before they go through treatment that would really render them not a candidate for something like a vasectomy reversal or some of the other treatments that we sometimes pursue. So it's always good to have that conversation just so you can talk about pros, cons of how difficult it might be to preserve sperm. And then even if you decide not, at least you've kind of had an informed discussion about it. Anything else you want to add on the sperm side?
No, I think that was a great summary.
All right, so let's move on to eggs. I know we talked about it more just because it's harder, Don't you wish you could just
It is. There's more steps.
Come in and have one visit and give your eggs and be done with it. But it's that time window, I think, that has been so limiting. As you mentioned, people who are facing this cancer diagnosis, their oncologists want them in the hospital. Let's get going. And so tell a little bit about kind of what has changed in terms of our ability to get people in a little bit more quickly.
I think, first of all, the important thing is for us to be able to see patients quickly when they do get a new diagnosis. So we take these very seriously, and we are always able to find a way to see people quickly when that new information comes in, 24 hours, 48 hours, 72 hours for sure, and have a consultation, make sure that all the questions get answered. Some people will want to have that whole conversation, understand how everything works, and then do a thorough thinking it over as to whether it's the right thing for them. Not 100% of people who do the consultation will decide to proceed, but oftentimes, yes, and we can make it go very quickly. There's a lot of education up front. We don't like to overwhelm people with additional information. Try to keep it streamlined, as simple as possible. But you can have somebody come in and learn what they need to know, get the medications that they need, do some really baseline testing with labs and an ultrasound. And you could start fertility stimulation medication as soon as the first night, theoretically. We usually have a little bit more time than that. We'll take the time if we have it. We love to look to the oncologist to share with us what their thoughts are about the timeline. They're usually more forgiving than what we are ourselves. They're usually like, no, you don't have to start tonight, maybe after the weekend or something like that. And by the way, do we have time for only one stimulation and retrieval cycle, or would it even be possible to sneak in a second? There oftentimes is a window. Say you have an adult person with ovaries with a new diagnosis of breast cancer, there might be a window between the time of a surgery for the healing and recovery before the initiation of chemotherapy, et cetera, or radiation. And that's your perfect window for the stimulation of the ovaries to retrieve the eggs and freeze them before the start of the chemotherapy. Many studies have shown no increased risk in cancer outcomes for people who take that short time frame to do the stim and freeze. And we oftentimes will add one additional medication, an aromatase inhibitor called letrozole, or you could choose tamoxifen, which is a selective estrogen receptor modulator instead. These are medications that are on the market specifically for breast cancer treatment and breast cancer prevention, and use them in conjunction with the ovarian stimulation cycle to keep estrogen levels as low as possible, if that's at all important to the oncologist. And it is for hormonally sensitive tumors like breast cancers that are estrogen receptor positive, for example. So you can get somebody started right away, add these adjuncts to help maintain more physiologic levels of estrogen throughout. People can be in and out stimulation and retrieval in less than a 2-week time period. We no longer need to do starts of cycles in the early follicular phase. This was the main thing that would lead to weeks of lead-in time to get the timing just right in a quote cycle. And now we've got a lot of experience with random starts. We do like to know where people are in their cycle, and that's what that initial testing helps us with. But we can start them early follicular, as we always have, if that's where they happen to be, or if they've been on birth control pills, well, then they're perfectly primed to just stop pills and lead in. So we love it when people come to us on pills.
That's one of the other big things I always say when I talk. Like if someone is like on the pill or has an IUD, like, great, please continue. Because I have had people who get a diagnosis and they think, oh gosh, I got to stop my pills because I want to freeze my eggs. I better get a period right away. And we're like, no, you don't need that anymore.
Keep so much better on. Yeah. But we can also do a luteal phase start. And the trickiest of all, but still we can make it work, is a late follicular phase start. We've got lots of different ways to lead in. So it doesn't need to be the obstacle or the barrier or the delay that it used to be, which is marvelous.
And sometimes these patients, again, you're going to so many medical appointments, and so one more can seem really overwhelming. But when we're talking about maybe a 2-week window, you're probably thinking about 3 to 5 visits during that time frame. And most of those are pretty fast, like 15, 20-minute, come to our clinic, ultrasound, blood draw, off you go. The only day that you need that whole day available is the day that we do retrieve the eggs because of that anesthesia. But that's the other great thing, is since we're just fertility preservation, we're not having to prepare uterus for pregnancy. We'd use typically that loop-run trigger hormone that we've mentioned in past episodes that clears your body much faster, because we want to keep that chance of someone developing hyperstimulation where suddenly now they're feeling miserable and bloated and sore from the ovaries that might cause an issue with other treatment. We want to keep that risk really low. So most people are still going to feel some bloating, but usually be feeling dramatically better just a day or so after the retrieval. And that also keeps that chance of anything that we did as part of that stimulation and retrieval causing an issue with their cancer treatment as low as it possibly can be.
Yeah, we do try very hard to return patients back to their oncologist as healthy as possible after.
Yeah, we don't want to make someone feel even worse, for sure.
And one of the nice things about egg freezing, too, is oftentimes when there's a new cancer diagnosis, you may not have had yet the chance to do all the other testing that you may wish to do. Like maybe your oncologist is going to end up recommending BRCA testing for you, for example, or you find out that you've got, some sort of familial cancer syndrome that you're a genetic carrier of. When you're freezing eggs, you retain all options for future testing of those eggs that make embryos for things like genetic disorders if it becomes a concern or something that you wish to prioritize, and you might not have those answers yet. So the earlier in the stage that you're doing the freezing, say egg freezing over embryo freezing, the more straightforward it is to retain all your options for the future.
And that's a great point. I feel like that's something that we still need to get the word out in the community more. I mentioned in the beginning how early on this seems so overwhelming for single women. And I don't want to imply that those that are with a partner should instantly be freezing embryos. A lot of time, even if people are partnered, there are a lot of reasons that egg freezing might make more sense. As you mentioned, it gives more time to figure out if there's something else you need to screen for. It also provides more flexibility. Before we had egg freezing, back when people would create embryos, that's where you often saw the most sad cases of people who survived their cancer, but the relationship did not survive. And then if their partner did not allow them to use those embryos, they weren't able to use them. And so creating embryos with somebody does make disposal issues a lot more challenging in the future if the two of you end up not being on the same page. Or if you end up not needing to use them. We don't always have that uncertainty. It could be that people's fertility is not, completely impaired and they might conceive fine. And then it can be hard to end up having embryos that you didn't need to use and have to discuss disposal. So we always have a conversation about pros, cons of freezing egg versus embryo. But the process for the person is going to be the same. It's just what we do once we take those eggs out of the body. Are we done, or are we going down that final step of actually fertilizing, growing out to embryo stage?
Yeah, and I would individualize that decision because it totally depends on a whole set of circumstances there. The other thing that I wanted to add too is just some reassurance about all of the studies that consistently show that in the offspring of cancer survivors, we don't see an increased risk of cancer, for example, in the absence of familial cancer syndromes, which are genetic and single gene and can be screened for if you wish. And we also don't see any increased risk of congenital anomalies or birth defects or chromosomal abnormalities. And I just think that that's a lovely reassurance for people who are in this situation to not have to worry about that.
Definitely. The other thing I wanted to add is we were talking a lot about fertility preservation before treatment, but one of the other times that I've seen people come back is when people say they didn't have time to preserve before they went through treatment, and now they're kind of in that recovery phase, but they're still not ready to build their family. And sometimes you will have this hit of your ovarian reserve. And so sometimes that window of reproduction that we would think you would normally have, you might be in your early 30s, but now when we do testing, your egg supply is severely diminished compared to usual age changes. Sometimes we'll have people that'll be a time that they want to come in and freeze eggs, because if they're not ready now and they end up trying in a couple years, if that supply has continued to go down, they might have even less options. So it's always good to at least have a conversation about, your individual testing and where you're at and what your goals are. And that way, again, you're always feeling like you're at least making the most informed decision.
Yeah, I think that's a really good point, especially on the female side. For people with ovaries, if you have your chemotherapy and there's a detriment, a hit to the ovaries, it can be somewhat temporary with corrective measures in place depending on your age at the time of the treatment. The younger you are, the better. And you may still be in a situation where you have a remaining egg supply is diminished compared to had you not needed that intervention, but you could still be able to capture fertility and preserve for future use. And it's definitely not a contraindication to freeze eggs or embryos or ovarian tissue after chemotherapy.
So let's talk a little bit about ovarian tissue freezing, because that's certainly our other big leap forward with that being non-experimental. Summarize a little bit more like where we're at right now in terms of data and outcomes.
Ovarian tissue freezing is a totally different concept, and it's so important that people know about this because it's really the only option that prepubertal females have. If you are a girl under the age of menarche, say, whenever that is, you're just not eligible for egg or embryo freezing for sure. And it's really the only option in this age group. Prior to 2019, ovarian tissue cryopreservation was considered experimental. In truth, it is still absolutely new. It's still an emerging technology, and we're still learning so much about it. Even if ovarian tissue cryopreservation isn't experimental, I would say ovarian tissue transplantation is. The hope is that if these are prepubertal girls now, then they're remote from their goals of family building, which could be 2 or 3 decades away. And that buys us a little bit of time to prove from a basic science and clinical standpoint what the reproductive potential is with this ovarian tissue. There are babies born worldwide, at least 200. There is no registry, so there's not a way to keep track of what these numbers are, other than case reports in the literature, which is inadequate. There are efforts right now, at least in the United States and other places, that do the same job or better of tracking outcomes to create a registry. So we're hoping to have improvements on that. There's 2 main things that you can feasibly do with frozen ovarian tissue in the future. One is transplantation back. You can take these small pieces of ovarian tissue and do a laparoscopy and replace them into the orthotopic location, meaning the same place where the ovary would normally be. If there's usually one ovary remaining, they would place it within that remaining ovary. If there's no ovary remaining, they can place it into the peritoneal sidewall in a similar location. And that way, people can regain hormonal function. This is the only fertility preservation option on the female side that allows for hormonal restoration, not just fertility. And people can cycle again and regain ovulatory cycles, and be possibly able to get pregnant on their own. That's the European model. If somebody is heterosexual and sexually active, they'll send that person home after ovarian tissue transplantation, and they'll have time to intercourse and report back. The American model so far has been a little bit different than that after ovarian tissue transplantation. It's mostly IVF cycles after, and these patients behave like somebody with diminished ovarian reserve, or even severely diminished ovarian reserve, as you might imagine. But you can still see positive outcomes because of the hope for well-preserved egg quality. So egg numbers are not high in IVF, embryo numbers are not high in IVF, but potential live birth is still very much a possibility.
And talk a little bit about the actual logistics. I think some people have this vision that you're like removing an ovary and like sticking that in the freezer, which is not really what's happening. So how are
And then taking it out, thawing it out and putting it back in.
Yeah, taking it out and like screwing it back in like a light bulb, which is not what we're doing at all. So how
like a light bulb.
Or Han Solo in Star Wars.
Yeah.
So it does require a laparoscopy to remove the ovary. The best strategy from a cost standpoint in the United States is to piggyback this onto some other procedure that requires an anesthesia and OR time, like port placement or something like that, if you can. And most often we've been removing one whole ovary and leaving one whole ovary in place. Studies show that if you remove a whole ovary, though, on balance in the lifespan, you might be facing a slightly earlier menopause. And there is a question about whether one whole ovary will remain the most standard way, or shall we move to a half or a third? And there's different practice patterns around the world, and a third of an ovary might do equally as well, or something like that. So all or a portion of one ovary is removed and arrives to our center and gets processed. And it basically is a bivalving of the ovary, and it's the outer rim, the cortex of the ovary, that has all of those primordial follicles that are so important. And the inside stroma is removed. And you need to make it pretty darn thin, less than 1 millimeter in thickness, and divide it into small pieces that will fit in these cryopreservation vials. And it is still slow cooling as the most standard method for ovarian tissue freezing. The most live births so far are still with slow cooling. It is possible to do it with vitrification, either an open system or a closed system. And all of this is still, an active part of investigation. So there might be more information about that coming down the pike in the coming years. Once these small vials of ovarian tissue is frozen, then we take pictures of it, because a picture is worth 1,000 words, as you know. And that way later the surgeon can plan for exactly how it is that they're going to do the transplantation. They can take an extracellular matrix that's embedded with growth factors and other materials to help the ovarian tissue with the seeding and the revascularization. Studies have shown that it's the time from the putting back in the ovarian tissue the first 10 days or so when it's revascularizing that we have the greatest loss in the total number of follicles. So the hope is that there will just be much more active research done in the coming years for how to minimize that loss and improve the efficiency of it all.
Is there anything else, Anne, that you wanted to cover in terms of like cancer treatment or medical treatments?
Not really. I mean, just briefly, and I know we could talk about this for a whole hour or two. Like when we are talking about childhood cancers, it gets into different issues of consent and legal, because now you're talking about people that can't legally give consent as minors, and you have to have that conversation too. And also for all of our patients who are freezing eggs, sperm, or embryos, all of our forms have information on there about disposal issues, but it's one of the things that, is often more in people's minds when they're freezing tissue with a cancer diagnosis. So it opens up all kinds of thought pathways about what you would want, and especially if people are partnered, that issue of posthumous reproduction. If you didn't survive treatment, would it be okay for your partner to conceive using your frozen eggs or frozen sperm? So these are all conversations that we have with people who are freezing, and that can be one more thing that feels so overwhelming. And that's also part of the reason I think it's really good for oncology teams to send patients to come see us, because this is definitely something that we are much more comfortable talking about and have a lot of experience and guides and things we can give to patients so that they can at least make this informed decision about what's going to be best for them in this moment. And we've had so many patients come back in the future that mention, as you said in the very beginning, the hope that this process gave them, that when they were in the hard times during treatment, feeling like they had this chance of a future family, which was really important to them, was actually a huge psychological benefit. So it's definitely not something that we want to discount. Any other final words you would like to say to a listener who's maybe facing this circumstance and feels totally overwhelmed?
Well, I think it's exactly as you just said, Anne. It's all about hope, hopefulness for the future, truly.
Well, thank you so much for your time today. You covered a lot of material very well. We really appreciate your time and your expertise.
Thanks for being with us.
Appreciate it.
Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review The Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.